Good day. One of the activities that a medical technologist may miss in his lifetime is the preparation of bone marrow smears. But if you are going to work in a hospital that specializes in um, children's diseases, so most likely you may be able to encounter the preparation of bone marrow smears, even the staining of these specimen. Although the process of obtaining a bone marrow specimen is not really that easy, it is considered to be a very important test to be done to make a proper diagnosis of hematologic diseases. So we use this to discover or confirm many different diagnoses, monitor hematologic and non-hematologic diseases, primarily tumors, and for leukemic patients undergoing chemotherapy. The examination of the cells and the tissues in the bone marrow is important and has been explored very well in the recent years. So they have used bone marrow culture to do cytogenetic testing, kinetic studies. They did isotopic labeling of the bone marrow aspirate, processing it for research using electron microscopy, clonal studies, and culture and other methods have become established. The specimen may be obtained in three ways. Number one is by aspiration using a special needle and syringe. The examples of this would be the Salah, Klima, and Islam's aspiration needles. Percutaneous trephine, in which the part of the bone is taken for examination. And thirdly, using surgical biopsy or open trephine that requires full operating theater practice. So in short, this is a major operation. Most bone marrow specimens for hematologic testing are obtained using the needle or using trephine biopsy. The aspiration procedure is actually simple, safe, and relatively painless because of the use of anesthesia. The site for aspiration would depend on the age of the patient and whether or not a needle or trephine biopsy may be required. In adults, the site for collection are the central skeleton, and usually we have the sternum. This is the best site for aspiration. The easiest to puncture and can yield most cellular samples. The only problem with using the sternum as a site for collection is that the patient may actually see the procedure, and this may lead to emotional distress. You can also perform aspiration of the bone marrow in the anterior or the posterior part of the iliac spine. So that means it's the pelvic girdle. The advantage of this is that if there is dry aspiration, so that means if there is no specimen obtained by uh, the needle, we can do microtrephine biopsy immediately. Right, so this is an example of a needle that is used for aspirating bone marrow specimen. So there is a stylet that can be removed. So the upper part is a stylet. This is the um, appearance of the patient while being collected with a bone marrow specimen. So this is in the posterior aspect of the iliac spine or the pelvic girdle. In infants and children, the sternum is thin and it's not really a very good site for collection. So in children under 12 years old, we use the iliac crest. For those who are under 2 years old, we use the active marrow in the long bones, for example, the posterior aspect of the tibia. In disorders with replacement of the hematopoietic marrow by other tissues, for example, in certain cancers, the marrow aspiration may actually be difficult or impossible. So a dry tap may be experienced. So in that case, we may need to do a needle or trephine biopsy. The minimum amount of marrow that should be aspirated is about 0.5 ml, and if we obtain more than that, most likely it's diluted with blood. So if it's diluted, we have to do careful preparation. It's desirable to concentrate the marrow cells and make sure that the blood is removed in the process. So how do we do it? It can be done in the following method. Number one, a single drop of aspirate on the slide about 1 centimeter from one end, and then quickly suck off most of the blood with a Pasteur pipette. Alternatively, we can place the slide on a slab to allow this, so that means the edge of the container with the bone marrow, and allow the blood to drain away. The irregularly shaped marrow fragments will adhere to the slide, and most of them will be adhere behind. Another method, which is maybe you're familiar with, is with the use of a smooth edge glass spreader. So in this case, we are going to prepare about 3 to 5 centimeters of a feather-like blood film. Okay, and we have to drag the fragments along the spreader to leave a trail of cells. So the only problem here is since most likely this is contaminated with blood, during the differential count, even those blood cells may be counted. So we can consider this satisfactory when the marrow particles as well as the free marrow cells are seen in stained films. The third method is by preparing a fixed film of the bone marrow and stain them with Romanovsky dyes for peripheral film. So you're familiar with hematoxylin and the eosin stain. But the only thing that you have to remember here is the fixation time should be longer so that the staining will be much better. So what else? The staining time should also be increased if you find the bone marrow to be hypercellular. This is an example of a smear where the bone marrow particles have been dragged to form a feather-like smear. Particle crushed smears. Aspirated bone marrow particles are isolated by crush preparation, so we can also call this a squash method. So by forming, by using two glass slides, you can prepare two identical preparations by pulling those two slides while they are pushing or while placing the specimen at the center of the slide. It will be rather thick, so it's difficult to stain. So we can see here a squash preparation, the upper one. Okay, and the second one is more like a meandering smear for cytological analysis. So it's like they just use like a cotton or something to spread the specimen in a zigzag manner. Okay, examination and assessment of the stained preparation. Right, so we have to visually check the slide. Okay, using the naked eye, and more or less you can identify which blood film is well made. The particle should be examined using a low power objective in order to check for cellularity and estimate if the bone marrow is hypoplastic, anormoplastic, or hyperplastic. So that means that the amount of cells that are present is described as we have said. The cellularity is expressed as a ratio of the volume of the hematopoietic cells to the total volume of the bone marrow in the preparation. It's judged based on the areas occupied by the fat spaces and by the nucleated cells in the particles. We will look into that later on. The normal marrow should be normocellular or normoplastic. However, the cellularity can also vary depending on where the specimen was taken. For example, in this case, for a person who is about 50 years old, the vertebrae, if you use the vertebrae as a source, you might get more um, cellularity in the vertebrae, about 75%. Sternum is about 60%, and in the iliac crest is only about half or 50%. If the percentage is increased for the age of the patient, we can consider that to be hypercellular. And if it's hypercellular, it may indicate the following conditions: myeloproliferative disorders, so different types of leukemias, chronic and acute leukemias, lymphoproliferative disorders, so affecting the um, lymphoblastic cells, can also be because of infections or polycythemia. So let's look at some slides. So this is what we considered as normal. So those spaces that appear like vacuoles are because of fat cells spaces. Now in this case, you can see a hypocellular marrow. There are more fat spaces, and it's about like half or a little less than half of the total space occupied by the cells. And then in this illustration, or in this micro photograph, you can see that there are more fat cells and there are less of the um, hemopoietic cells. So that is considered to be an aplastic marrow. What about the hypercellular marrow? So in this case, you cannot see any more of those fat spaces, and mainly what we see are nucleated cells. The bone marrow is said to be hypocellular if the percentage of the cells, hemopoietic cells, is decreased compared to the number of fat cells that are present. So conditions like this may be encountered in aplastic anemia and in drug toxicities. The term myeloid to erythroid ratio, or M is to E, is an expression of the myeloid cells that we see compared to the erythroid compartments. It is calculated by counting or classifying about 200 cells, leukocytes of all types and different stages of maturation, and we count them. In the normal adult bone marrow, the normal ratio should be about 4:1. An increased ratio would mean that there are more leukocytes, and there is depression of the erythroid series. And if there is a decrease in the ratio, so that may indicate that there are more erythroid cells being produced compared to the WBCs. The myelogram. When we say myelogram, so this is an expression of the incidence of the different types of cell types in the bone marrow. So it's more like a differential count. So we don't normally do this. It is not mandatory because it's going to take a lot of time to perform, and it has really little usefulness. The count is unreliable because of the irregular distribution of the bone marrow cells and possible inclusion of cells coming from the blood. So if it should be attempted, then a minimum of 200 cells should be identified. So there is a naturally variegated pattern in the bone marrow and the irregular distribution of the bone marrow cells that it may be affecting the differential count in the bone marrow. There is a variability in the results. Minor degrees of deviation from normal occurring in the disease are difficult to establish. So this is an example of the myelogram, and indeed it's really little difficult, especially for the inexperienced cytologists or medical technologists. So it may be difficult to identify these different cells in their different stages. Okay, so that was the last slide for this presentation. Thank you for listening and watching the video. I hope you learned something new. Thank you.